Okay, awesome. We're going to give everyone just a couple of seconds to log in here. Since we're at the top of the hour, we'll go ahead and just jump into a couple of housekeeping items. My name is Brooke. I'm a speech pathologist here at Tim's Medical, and I am really excited and honored to have Dr. Mallory Moore with us this evening to provide tonight's presentation. A couple of housekeeping items before we get started. This webinar is eligible for 0.1 ASHA CEUs or 1 PDH. If you'd like ASHA CEUs for attending the session, we ask that you stay for the entire duration of the webinar and that you complete a brief survey within 7 days. I'll put the link to the survey in the chat, and it will also be sent out via Zoom twice via email. So if you complete it, just disregard the second email. And then the replay for tonight's event will be up on the Tim's website within less than 48 hours. And Dr. Moore has also included a PDF of her slides, so that will also be linked with the replay. And if you'd like a certificate of completion, just send us an email at tims-unum@tims.com. And if you missed any of this information, because it was a lot, it will all be in the chat. And then, like I said, it'll be sent out to you via Zoom as well. So with that, I'm going to hand over the floor to Dr. Moore. And Mallory, it looks like the slides went away, so I'll just give you a second to reshare, and then I'll jump in. That's okay, no worries. But I'll hang out here just to make sure everything's good, and then we will kick off the event.
Okay. Oh, there it is. Okay.
Perfect.
Can we see it okay? Okay.
Looks good.
Every time I lecture, there's always some technological issue, so I'm not surprised by that whatsoever. So, well, thank you, Brooke. I appreciate it. And thanks for having me. And I'm excited to share my presentation today. So our presentation is Building Bridges, Breaking Barriers, Advocacy and Funding that Transforms Dysphagia Care. So this is our time-ordered agenda. I will do my best to try to stay on track. I'm a little verbose at times. These are our learning objectives. We are going to identify various forms of advocacy within dysphagia care, describe how leadership development opportunities can enhance professional growth and empower clinicians to advocate effectively. We will examine successful models of funding and collaboration that have supported improved access, equipment, and programming for individuals with dysphagia. We will apply practical strategies to transform advocacy ideas into actionable, sustainable initiatives within your own, hopefully your own, clinical or organizational settings. And these are my disclosures and non-disclosures. So financial, I receive an honorarium from TIMS for this presentation. And then non-financial, I serve in volunteer leadership roles for a few different board of director groups, nonprofit organizations, LANA, Lymphology Association of North America, the Ozark Neurological Foundation, and also Larry Speakeasy. Just a little bit about me. So I am a speech language pathologist, and I have been in practice for 15 years. My experience has included mostly outpatient rehab. I have been at my facility since my clinical fellowship. I love my facility and outpatient rehab. At first, when I started, I really thought that I was destined to be an acute care therapist, and I have done work in long-term acute care and I love those, and also inpatient rehab, and I love those settings. But as I've grown older, I've just really fallen in love with outpatient rehab. I've also served as a director of therapy before. And my expertise, I guess, if I were to say if I have an expertise in the field, I do have my doctorate in speech language pathology, and I'm very, very passionate about head and neck cancer care and neurodegenerative diseases. So I work in two multidisciplinary clinics at my hospital, one for ALS and then another one for Parkinson's disease. And then I also primarily see a lot of my patients for head and neck cancer care for their survivorship. And I am a LANA. I'm a board certified lymphedema therapist, and I am also a board certified specialist in swallowing and swallowing disorders. And I think I was asked to do this presentation because over my 15 years of being a speech language pathologist, I have received over $300,000 worth of grant funding. And so that's what I'm going to be talking with all of you about today. So first, we're going to talk about the many faces of advocacy. I think sometimes when we think about advocacy or when we hear the word advocacy, we picture something really big or formal, like presenting to administration or maybe even writing to our legislators, which all of that is incredible and very important and is a great form of advocacy. But there's also smaller types of advocacy that happens in our everyday clinical moments. So that type of advocacy can happen when we recognize a gap in care and we decide that we're not going to ignore this gap. When we see a patient not receive a service or not know about a service that we provide and we educate them and we educate physicians about what we do as speech pathologists, that is advocacy. And even when we're mentoring other clinicians so that they feel more confident in managing complex dysphagia care, that's a form of advocacy. So advocacy is really this process of identifying a need and then taking action so that we can improve our access, our quality, or our outcomes for patient care. The most familiar form of advocacy is patient level advocacy. This is what we do, day in and day out. I think this is kind of what most speech pathologists, when we come into this field, this is, I guess, kind of what we're born to do or what we're really passionate about doing is when we see that patient and we really want to help them. I always describe I have two young boys, a 9-year-old and a 6-year-old. And when they ask me what I do, I try to simplify it and I say, I'm a helper. I like to help people feel better. So this is patient level advocacy. When we have a patient that maybe has concerns about aspiration and we have no access to instrumental assessment, or maybe we just haven't ordered that form and we identify it, that's advocating for the patient. And when we are talking to the physician about the difference between maybe a modified barium swallow study and a FEES and why we might need one versus the other for a patient's plan of care, that's advocacy. When we have a patient maybe with head and neck cancer and they're told that their swallowing difficulty is just a part of treatment and it's their new normal, us explaining to them and teaching them that proactive dysphagia care and proactive management and continuing to work with us afterwards, that's advocacy, and that's making a meaningful difference for these patients and can really change their life if we can get involved early on. When a patient understands or starts to learn about maybe even different communication options. So I see a lot of total laryngectomy patients. Advocating for them is teaching them that they have a wide plethora of different modalities of communication and supporting them of what they feel most comfortable with. That's advocacy. So, one of the things that I learned is that patients often don't know what services they should have access to. They might not know that swallowing therapy even exists. How many times do we walk into a room and they look at us and they say, I'm talking just fine, and then we educate of all the, amazing different things that we do to help with these patients and their care. So part of our role, it's not only just providing care, but it's to help patients understand what appropriate care can look like and what good, robust care can look like. The next layer of advocacy is our service level advocacy. And this is where we zoom out just a little bit from the individual patient. We start asking, is this a pattern that I'm seeing? So, I think about maybe we have one patient that missed an instrumental assessment. But what if we have a lot of patients with dysphagia and they're not being referred for those critical tests? Maybe we have had one laryngectomy patient that has trouble accessing supplies, but what if we really don't have a clear process that's set up for these patients after their total laryngectomy to learn about these supplies? Maybe we have one head and neck cancer patient that was referred really late, like 10 years too late. And then maybe we start to realize, hey, wait a minute, our system doesn't have a standard referral pathway. So this is where our advocacy can really overlap with program development. And this is where we start seeing how do we help this one patient to how do we build a system where the next patient hopefully doesn't have to fight as hard for this needed service for them. Another major face of advocacy is equipment and resource advocacy. And I think this is, a really big topic in our field. I kind of joke with my colleagues that we've kind of developed ourselves into hoarders, because any type of material that we get, we keep, because and historically we haven't been given things in the past. And so whenever we do get a tool, we're going to keep that tool until, it's not usable anymore. So many of you might be in that same boat. So for us as speech pathologists, thinking about shooting for the moon, we might ask for maybe FEES equipment or maybe modified barium swallow study equipment. Maybe we want to look into funding sources to support laryngectomy patients because that can be expensive. If you don't have a set laryngectomy program already started. There's different tools that you have to have beforehand, and you have to kind of be prepared for a lot of different situations. So we might need funding support if we have a bigger population of those patients that need our help. Maybe there's even specialty supportive chairs for our pediatric cases with dysphagia. Or maybe there's biofeedback tools. There's so many great new things that we have out there that are available to help give that needed biofeedback for patients so they can connect better to their bodies, and have better outcomes for rehabilitation. But I feel like this is kind of that area where clinicians get stuck because we know what the patient needs, but we may not know how to ask for it in a way that our administrators or maybe potential funders can understand. And so I'm hoping that I can answer some of those questions today. So really, when we look at these requests, it can't just be we want this because it would be really nice to have it or it would be cool. It needs to be connected. It needs to be connected to patient care, maybe patient access. So instead of a patient waiting 3 months, we're able to get them in within a month. Hopefully, it's helping us with our efficiency. Maybe it is checking a box for better safety outcomes for a patient, or maybe it's bringing in more revenue for your department, or it's a community benefit, or maybe it's a mission alignment. And I'll talk a little bit more about that a little bit later. So, one area of advocacy that I think we sometimes overlook, too, is also advocacy for ourselves within our own profession. So, in dysphagia care, advocating for ourselves really shouldn't be considered separate from patient care. It's a part of patient care because when clinicians are under supported, if they're under trained or isolated or burned out, our quality and the sustainability of our care is going to be affected. So, mentorship, leadership development, advanced training, all of that is advocacy. So I get to do a lot of really cool things in my practice, and I get to do unique things like do fees and video stroboscopy and change prosthesis. But that would not have happened if I didn't have the support. To go for specialty training to do that. So, and for some of us, we do have to pay out of pocket. In other cases, we might get maybe external funding to help with that. So, another thing to think about for advocacy is building this network of clinicians who we can connect with and consult with, and learn from. And I think Tim's Medical has just done a really phenomenal job of building this network with all of these different continuing education, free continuing education possibilities. So a shout out to Tim's for doing this. Um, Going back to dysphagia care, when we enter these complex clinical areas, sometimes we're doing that maybe even before we feel fully ready. So head and neck cancer, laryngectomies, tracheostomies, ventilator management. I don't see pediatrics. I only see adults, but those pediatric cases in the NICU, oral aversion cases, all of those really need mentorship, and they need more training, and it can really make a tremendous difference. So when we advocate for mentorship, we're not only helping ourselves grow as clinicians, but we're helping build the capacity within our profession. And I really love the idea that mentorship will turn individual expertise into this shared capacity. And I like to think that when one clinician receives training, one clinician will grow. But when that clinician is going to take time and mentor others and develop protocols and share resources, the whole system grows. And hopefully that comes into or that builds into something that lasts past, our lifetime within a particular facility. We want to see that continue even if we retire or if we move on to a new place. Okay. Another important part of advocating for ourselves in our profession is really recognizing the value of leadership development. And, leadership development doesn't always mean that you have to pursue a formal title or become an administrator. Again, it can include mentorship or specialty training or committee involvement or board service. Sometimes it might look at professional organization participation, like your state organization or national organization participation. Sometimes it's looking at your own, world and looking at maybe a quality improvement project, or grant writing or program development, or even simply just learning how to communicate more effective with some of those decision makers. So many clinicians, especially those working in areas like dysphagia, leadership development is going to help you provide or learn the structure and hopefully give you more confidence to move from seeing the problem to doing something about that problem. It's going to help you learn more about identifying different gaps in care, organizing those ideas, and communicating those needs clearly. Leadership development also helps build relationships and understand how change happens within a system. I've been really lucky to be a part of a few different leadership development programs. I did one with ASHA, and that was just wonderful. And then we've done a few different leadership things within my own hospital system. And one of them we did it years ago, and it was a system-wide project where each department would kind of pick out maybe one or two things that we felt was a perceived issue. And then we actually started taking data on that perceived issue. And once a week, administrators would walk through and we would take a time out and we would present our findings each week. And it was really amazing to see that maybe a leader in a totally different area would say, "Oh my goodness, we've run into that too." Or they'd say, "Actually, we found a solution to that problem. Let's set up a time to meet and we can problem solve this." So um, in that way, leadership development can be a bridge between clinical expertise and a system level change. So, us being able to identify this is something that is bothersome for us on a day-to-day standpoint. And, I'm identifying this as a speech language pathologist. And now we have an administrator from a different department that says, "Oh, wait a minute, I can help you here." So, it can really be helpful to put yourself out there and look for those different opportunities, even if it might seem a little bit scary. But ultimately, leadership development, it really should help give clinicians the tools to advocate more with more confidence, more clarity, hopefully more strategy. And it can help us recognize that we don't have to wait necessarily for someone else to create the change. We can develop the skills and relationships and the vision to be those change makers. And leadership does not, I mentioned this before, leadership does not always mean having that formal title. It usually starts with noticing that problem and being willing to take that next step. So sometimes that next step, it's going to be a simple conversation. Like the example that I gave before, it could be collecting those data points of how it's impacting patient care. And then sometimes after that, we take that data and maybe we take the time to write a proposal or to write a grant that we think that would help with that, whatever that gap is that we identified. Sometimes it's joining a committee, or maybe it's even saying yes to a leadership opportunity, maybe before we even feel completely ready to do that. I feel like I've encountered that several times, but it just takes one person to say yes and be willing to put in a bit of extra work to help with, the greater good and the bigger cause. And this is where we can see advocacy becoming scalable. So patient level advocacy is going to help that one person. Service level advocacy is going to help a group of patients. And leadership advocacy can change the way an organization or maybe the community or the profession even approaches a standard of care. When we talk about this advocacy today, I want you to think beyond just that one definition of advocacy. Advocacy can be, again, talking with a physician, writing a grant proposal, maybe making a new referral pathway or mentoring a new clinician. It could be asking for equipment, joining a board or a committee, or even as something as simple as creating a patient handout that's really good, but the whole system says, oh gosh, we've needed this. And that can help the entire group. Okay. And ideally, we want to hopefully build something that outlasts us or something that can be refined even better with each iteration. The common thread that we have here is that advocacy is going to identify a gap, and we're going to be taking this intentional action to close that gap. And when we recognize these different forms of advocacy, the next question is going to be, how do we move from identifying a need to actually securing the support to address it? And this is where relationships, leadership, and funding pathways become so essential. So when we think about grant writing or funding, it's easy to kind of think about like an application by itself as maybe that's our starting point. But in my experience, the application for me is rarely where the work begins. Now, having experience with doing some grants, it gives me kind of an idea of what questions I should be thinking about. But really, we need to start with looking at our clinical practice. What is continuing to show up? What is that gap? So, a few examples, maybe someone is having trouble accessing instrumental assessments, or maybe the clinic doesn't have the equipment to provide a service, or maybe our head and neck cancer patients aren't being referred enough. Maybe our clinicians are trying to build a specialty service, but they don't have the tools or training or the infrastructure that's needed. And this is where we can think about funding. We don't want to think necessarily about the form, but we want to think about the need. And then before we can ask someone to fund it, we need to be able to very clearly explain what the problem is, who's affected by it, why does this matter, and what could change if the right resources were available, right? Um, the application, of course, is going to matter, but strong funding requests are going to be built long before this application is even submitted. It's going to be built through observational data, relationships, planning, and the ability to communicate the impact of what's going to happen. So once we've identified the need, the next step is to understand who else might care about that need, right? Um, a grant application may just have one person's name on it, or maybe we have multiple people. Relationships are going to create the pathways for the grant. Some of the most important steps that we're going to be looking at is not the writing of the proposal. The big thing you want to look at is having a conversation that helps you understand where that project is going to be fitted or fitting in. So that might be first, if you have a new idea, first you want to talk with your departmental leader, right? Your direct manager, and you really need them to be your champion and their support. You might also look at maybe a physician champion. I've done that before with some of my grants. Of course, my manager has given me their blessing before I've done any of my grants or any of my crazy ideas. But sometimes adding in a physician onto it, I go and I pitch my idea and they say, well, yeah, that makes sense. Of course, I would support you in this. And just even having their name connected to the grant can make a world of difference. Maybe your hospital system has a foundation officer that you could get to know and kind of learn about the different opportunities that they have within the system. Maybe there are some nonprofit partners that are out there, or a colleague, or maybe there's a former patient or a caregiver that has been greatly impacted by what we have done or what their experience has been. And maybe they know somebody that would like to donate or help. And these conversations will help clarify the need, identifying the right funding pathway and strengthening the project before it's ever submitted is so important. And it's going to help us also avoid asking for support in a way that's disconnected from organizational priorities. So for example, a patient might say, we need this equipment, but a much stronger conversation is going to sound something like, we're seeing this patient population. This is a current barrier. This is how equipment would change that access or that outcome for that patient. And I'd like to understand if there's potential foundation or donor or a service line or a community benefit pathway that might align with helping me with this need. And that kind of conversation, when you sit down and you start, you know, looking at those opportunities, that's going to turn this into a shared problem solving opportunity. It's not just a solo project. A few personal examples of mine. So, as I mentioned before, head and neck cancer has always been a very big passion of mine, and and of course of my manager too. She's always been, on board with me. And one of my biggest goals is to try to make a good, strong referral pathway for these patients so that we are seeing them prophylactically. We're seeing them before they've had any of the big medical interventions. And so, knowing that I had that support from my leader was always in the back of my mind. But for my hospital, I think every 5 years, they do a really nice awards dinner, just saying, thank you for staying with our facility for so long. And I happened to be placed with the vice president of somebody within our hospital system. And I really didn't realize that they were the vice president of that particular area at the time. But the person was very polite, and they're asking me what I do. And, I can't help myself. And I start talking about, all the things that I love about being a speech language pathologist and my passion for head and neck cancer patients, and how I'd really love to see this program grow. Well, that I was just lucky enough that that was the right person to talk to. And that person became a strong advocate for us and helped me get connected to other people who shared similar sentiments as I did, and helped us get a better referral pathway started. So lucky, but it was a relationship, right? A relationship started with just a really simple dinner conversation. Another simple example that happened with me. I had a personal appointment with an endocrinologist, and it was my first appointment. And again, I love being a speech language pathologist. And so, she asked what I did, and I was telling her, and I said, I work for this hospital system. And she goes, you know what? We know that there's a couple different swallow study options that are out there, but some of us providers get confused with what those options are. Do you think you could create a handout for us? And I said, absolutely. And so again, I talked with my manager and I said, hey, she asked me this. I'm more than happy to take some time and to make something. And I made a little quick handout that had, what's a modified. I even put a picture of that lateral x-ray, what's a fees. And I put a picture of, us doing a scope. And then, what's the difference between a clinical swallow evaluation. And then also I put in, what's a barium swallow versus a modified barium swallow. And then the other thing that I put in there was, this is the order set that you need to put in. So I tried to make it as an easy button as possible. And, as a team, we said, yep, this looks good. We sent it along the way, and the endocrinologist team have said, wow, this has really, really helped with deciding what we need to do for referrals. So, just something as simple as that. You never know, just the smallest act, I think, can really make a big difference. I feel like a big piece of this that's incredibly important in my own advocacy and grant writing journey is giving back to the community. I do think when we look at volunteering, I don't think that we should look at this at all as a strategy. I think that is wrong for all the wrong reasons. We need to look at volunteering as, doing the right thing, and because it is the right thing to do and it's a passion of ours. So, the groups that I volunteer for, it's because I agree with their alignment, and it's something that I feel passionate about, right? So I purposely choose my time to volunteer with these groups because it aligns with what means something to me. So, but part of that too, with that volunteer opportunity, or with these volunteer opportunities, it's opened doors and it's opened connections. And that organization, maybe an organization that I volunteer with, maybe they're not a funder for me, but maybe they know somebody who wants to donate to our cause. some of these strongest connections I've made have been through this volunteer work, nonprofit involvement, board service, or just even being, willing to help out without any expectation in return. Those types of experiences have allowed me to meet really great people out of my immediate clinical environment. And you'd be surprised, a lot of those people, they care about patient access. They care about quality of life and patient support and community health. And they also want to give back to the community. And you'd be surprised, you talk about your experience as a speech language pathologist, and, maybe they have a family member or a friend that needed our services, and they saw what great things that we did and they want to give back. So, really think about that opportunity. When you're involved in the community, people, I feel like they really begin to understand who you are, and they understand what you care about, what patient populations you serve. They might not understand, the nitty-gritty of dysphagia care, or even they might not even know what speech pathology does within a medical setting. But, through relationships and service, they're going to start to see our impact over time. And that visibility matters so much. Trust matters, gratitude matters tremendously. Um, when people see that your work is rooted in service and it's not just, I'm just asking for resources, it really changes the nature of this conversation. And I mentioned gratitude. I feel that gratitude is a major part of this process. So when you have somebody that's supporting your project, or they're making an introduction to for you to meet someone that might support your project, or if they volunteer their time, or they donate funds or anything like that, or they open a door for you, that person deserves a very sincere appreciation, a sincere thank you. So, don't forget to write that thank you note, or give them an update, or tell them about the outcomes that happen because of their support. And, that little gesture, it really can make a big impact, and it can really go a long way. And conversely, if someone is doing all of these things for you to help support you in your endeavors, and then we don't say thank you, that can also, close a door. That group of people or that person that helped out might say, well, they really weren't appreciative of my time. I'm not doing that again. So we want to make sure that we're building that trust and showing our gratitude. So these are just a few ways that I've done this. Over the years. So I'm actually more of an introverted type of person. So when I get up to talk in front of a lot of people I don't know, I do tend to get a little bit more on the shy and nervous side. I do enjoy it, but I do get nervous. But I make myself do this because it's the right thing to do. So here you can see I'm very, very pregnant in this picture. And this was at a charity golf tournament where the funds come back and they help support one of the clinics that I work in. And so I was asked to give just a short speech and to talk about what I do as a speech pathologist. And to show how their support is meaningfully impacting our clinic. And then over here, we had some of our bigger grant funders coming into our clinic, and we were showing them what our clinic was about. And you can see I'm over here, we have a speech generating device. So this was for our ALS clinic. And I was showing them what the actual meaningful impact was of that speech generating device. And I know that's not necessarily dysphagia care, but it's communication, and that's part of what we do as speech language pathologists. And so taking the time and showing them what their funding potentially supports can make a really big difference. One thing that I've learned is that funding does not always have to come from that first place we expect. So, when I first started out, I just assumed that if my department didn't have funds, then that was it. That was, we were kind of SOL, sold out of luck. But that's only one possible pathway. Now, again, I have to really reiterate. First you got to go through your manager. It's so important. You have to have that partnership and trust, and you have to be on the um, same ground level and playing field of, let's say that you're trying to get fees equipment, and maybe there's not enough department funds. Well, if you go off and you find funds elsewhere, but you haven't let your manager know and you're, moving forward with these big plans, that's probably not going to go well. So you really, you need to be aligned. But other broader things that we can think of or other opportunities for funding could maybe your hospital has a foundation, or maybe the organization that you has a foundation. Um, Again, there could be a donor who's really passionate about cancer care or neurological disorders. Um, we have, a few people in our community who's really, really passionate about neurological disorders, and they've been tremendously helpful. More recently, this past year, we had someone who was very passionate about head and neck cancer care, which was great. And they were doing a percentage match for people donating. So it was kind of a system-wide goal for even employees to kind of donate. And then that main funder was trying to match it. So, even contributing some of your own funding can be helpful too. And sometimes maybe there's community foundation support, even for sometimes for my own patients, if they need new dentures, or if they're maybe they need like a palatal lift or something like that, or maybe helping with even getting to rides. We have lots of different opportunities to try to help with that. But I even encourage them, if I can't find something, reach out to your church, or try to find other organizations in the area that might be willing to help. So there's lots of great opportunities out there. Sometimes there's nonprofit partnerships that are out there. If you look up a specific terminology, and then Google nonprofit, you'll probably find an organization that aligns with what you're hoping to find. And they might not be able to fund everything, but maybe they're getting, a piece of the portion for you, which is helpful. Sometimes there's service lines funds that are available. Sometimes there's internal innovation opportunities. My facility here, they do once a year, they kind of do an innovation competition, so to speak, and it's really cool. And people from all across the hospital, they submit their ideas, and then they actually, I think they narrow it down. I haven't been to it personally, but they narrow it down, and then they take, a certain set of finalists and they move it forward, and then, they keep kind of eliminating. But ultimately, there's usually 1 to 3 people who their ideas are taken, at kind of top priority for the system, and there's a lot more support for those top ideas to try to make a meaningful impact. So lots of really cool opportunities. Um, and again, it doesn't mean that every idea is going to be funded with these different types of funders out there. But what I want you to, kind of take away from this is that because we hear a no, that doesn't mean it's the only option that's there. Be creative and really try to get out there, build relationships to see, if there's other pathways that are available. And once we understand what those possible pathways are, then we really need to know how to clearly communicate what that request is. So, one strategy for me that I feel is really helpful when I'm writing grants is to intentionally connect the request to that organization's mission and values. So, most organization is going to have mission and values connected to it. So one of our values is to be the best for those who need us. There's some organizations that are maybe specific to a certain patient population. So maybe Parkinson's or maybe autism. There's a wide variety of organizations, but if I go to an autism foundation and I'm asking for funding for Parkinson's, that doesn't match. So we want to make sure that we are matching, what we need to who we are asking for that need. So when we are looking at those missions and values, that's going to be your roadmap for how to frame a really strong proposal. So instead of we need this equipment because our department wants to expand our services, we could say something along the lines of this project supports our organization's mission by improving access to timely and evidence-based dysphagia care for patients who currently experience barriers to assessment and treatment. Okay. So we really try to hone in on what is our ultimate goal for these people. And that shift really matters. It moves the proposal from a department-centered request to a mission-centered investment. And that's helpful because the decision makers who are reviewing these requests through the lens, they're going to be looking at it from the organizational priorities. They're going to be asking, does this align with who we are? Does it support our patients? Does it improve our quality or access? Does it serve the community? Does it reflect our values? And when we can show that connection of here is the project or here is the need, and this is how it connects to the mission and values, it's going to make it a lot easier for those key stakeholders to understand how important it is of what we're asking for. Um, a really helpful grant writing question is, how does this project help the organization live out what it says it values? And if we can answer that clearly, our funding request is going to be just a whole lot stronger for us. And when we have that aligned, when we have the aligned project with the organization's mission and values, we can then start having that clear, fundable ask. And this is where that grant writing and the advocacy really starts marrying together and coming together. A fundable ask is not just a list of items that we want, it's that clear explanation of why that request matters. As a clinician, we often understand that need, that patients need that, they might need those instrumental assessments or updated swallowing technology or funding for even just patient education materials. We know how important that is. But the funder needs to understand that bigger picture. Who's affected? What's that current barrier? What happens if the barrier continues? What is that downward trajectory? What could change if the project is funded? So we have to have a little bit of a crystal ball available, or a hypothesis that we are offering along with these proposals. And some of the proposals that I have put together or some of the grants that I filled out, that's one of the questions sometimes is what is the sustainability of this? What is the plan after this funding is done? Because sometimes grants they have additional funding the next year and sometimes they don't. So you really have to see does this funding request is this a one time or are we going to need continued support here? So it's good to really have that foresight and dig into it and see before you're starting to make that request. I think this helpful framework might help all of you. So you think about the need, think about the patient impact, the proposed solution. Of course, you have to think about the cost, the outcome, and then the sustainability here. An example might be we need updated instrumental assessment resources because patients with dysphagia are having barriers to timely and comprehensive examinations. With your support, we can improve access to assessment, strengthen treatment planning, and improve communication across our care teams. And then how about we will measure success by tracking the number of patients served, referral patterns, wait times, and provider or patient feedback. And then we can also say maybe this project will be sustained through clinical integration, ongoing referrals, and continued service development. So the goal is to help the reviewer or that decision maker see the connection between the resource and the impact and then the sustainability. So this is an example of when I was working on trying to upgrade our endoscopy system. So we started off with those fibroscopes. And this particular funding opportunity was from Children's Miracle Network. And this was a big funding ask, a really big funding ask. And so for this particular ask, I was asked if I could come and present, a fairly short presentation to the board. So there was probably I don't know, like 15 to 20 people in the room. Thankfully, they had access to a projector for me. And, a picture is 1,000 words. And so I talked about, and I serve pediatrics for endoscopy for voice disorders and some swallowing disorders too. And so, I just showed them the pictures and I said, this is our fiber scope. It's a grainy picture. We don't get that clear, crisp picture that we want. And it's so important for us to update our scopes because look at how clear this is. We can clearly see the retinoid cartilages here. We can see that they're swelling, and so I went into these differences between these two different types of scopes. And everyone, I think, in the room was sold on it because they could see how important this crisp picture was. And, we wouldn't need to refer them out maybe to a different facility. We could do this in-house and take care of this critical need here. So again, even just using a simple picture and showing them this is exactly what I'm talking about, not just this abstract, well, this picture just looks better. This is showing them how much better it is. And again, thankfully, we got that grant request. Um, so these are some of the places that I've had luck over the years with grant funding. And as you can see, a lot of them are very local to my area. And hopefully you guys have local opportunities in your area as well. So I have attempted like a big national grant before and I haven't gotten it. I've written several grants before that I haven't gotten. And that's okay. That's just kind of the nature of the beast. But these are ones that I've had success for in the past. And I'm going to go over some of these grants. And if you go through and you calculate it, this does not equivalent to that 300,000. I really tried to kind of stick with grants that were more pertinent to like dysphagia care or maybe even voice care. And I'm also not going through all of these to show, oh, look at me, by any means. It's to show, these came over time and over the years, and little bits really added up over time. So most recently in this year, we our old fee system unfortunately died. It happened suddenly, and we needed new equipment. So it was kind of a rush order. I'd like to think we have a robust fees and video stroboscopy program here. And so we're very fortunate to have funding support for that. I work on the nonprofit board for Larry Speakeasy, and I helped them write a grant to get 1,500 to help support the services that we provide for them for in 2022. And you can see there's a gap between some of my grant writing. So I really try not to request for things if we don't necessarily need them. There's other departments, there's other people that have needs. So I try to be really mindful of that to make sure that other departments are also getting the necessary funding that they need. And if we're doing good and we're coasting, I'm not asking for things that we don't need. Back in 2022, I got a really nice grant for our COVID-19 survivors, and we got a whole bunch of respiratory muscle strength trainers, which was really great. And we were able to give those to patients for free. So, they didn't have to pay for that. And then that kind of also expanded to other types of patients, not just COVID-19 survivors. In 2022, we also upgraded a portion of our endoscopy equipment. Oftentimes, when you look at endoscopy, maybe you need a new scope, or maybe it's the light source that needs upgraded, and it's not always a full refresh of the whole system. Maybe it's just parts of it. So that's a lot of what you'll see here. In 2021, we did an upgrade to our endoscopy system. In 2019, this one's kind of a silly one, but it really helped. We see a lot of people with vocal cord dysfunction or ILO, and we needed a treadmill. And so the Sports Hall of Fame had a grant, and I asked for a treadmill, and we got one. So that was very unique. But it had a lot to do with a lot of our athletes that have vocal cord dysfunction. In 2018, we got an SEMG system. In 2017, we got a BITS program, which is not dysphagia related, but again, all of us, it's rare when you're only working on dysphagia. So we work on cognition and all the other things too. We were able to get some IOPs in our facility back in 2017. In 2017, we also got our very first distal chip scope, which was really exciting for us. In 2016, I was able to find funding to help cover the cost of my own personal dissertation, which I did a simultaneous modified barium swallow study and fees. And so we were able to bill for one, but the other was not a standard of care because you don't usually do those at the same time. So we needed funding to help cover that cost. And we were able, thankfully, to find community support for that. In 2015, we were able to upgrade some of our stroke and traumatic brain injury assessments, which was exciting. 2015, again, we got a new scope station then, which was really exciting, and we had some new scopes at that time too. In 2015, I also got a nasometer for our cleft palate clinic, which was exciting, and we also got an ultrasound machine, which was really kind of more so for biofeedback for articulation, but we have it. And in 2014, we had our video fluoroscopy station upgraded, which was my favorite. And this is why. This is not our original, but when I first started working, gosh, when did I graduate? 2011, with my master's. So when I first started working, this was our station. Essentially, it looked like this. We had a really big, bulky, TV box with the dials, and everything was recorded on VHS. So this was not a robust system. If we wanted to take a picture, we would have to take the VHS tape and take it to a separate part of the hospital that had a special machine that we'd put in, and we'd have to dial it to that right moment that we needed. And oftentimes it would skip because it was a really old station, and then we'd print out a physical picture. So again, this was my favorite because this brought us to a much higher level of care in our facility. And I really was excited when we got this grant. And I think it was one of it was the bigger moments for our department for speech. So that was fun. When I look back at funding opportunities I've been a part of, the common thread really is that it really didn't begin with the money. Of course, that's always in the back of our mind, but it began really with the need. What do we need here to be more successful? And in some of the cases, as you could see, that need was better equipment. Sometimes it was better education for patients or more comprehensive dysphagia services. Or extended support for individuals with really complex communication and swallowing disorders. But that funding was just a part of the process. The more important piece was learning how to clearly explain that problem, to identify who else cares. Am I the only one out on this island that cares? No, I'm not. There's a lot of people out there in the community and within my hospital that cares like I do, and working on connecting that project to this much larger mission. And again, that might be the mission of the hospital. It might be a mission of a different nonprofit organization, or maybe maybe it's the mission of a donor that's out there or a community partner that just is sitting on, some funding that wants to help, but they don't know how to help. Um, and when we can explain not only what we need, but why it matters and why that change is important, we're going to be really effective advocates out there. So remember, funding is not the finish line. It's the opportunity, and implementation really determines whether the opportunity is going to make that lasting change. So when that need is clear and the potential funding pathway has been identified, then we have to implement. So, this is a multi-step process here. We're going to receive funding or approval, but again, it's not the end of the process. We have to really think about what's our next step to make this into a good workflow, a good service program, and how is it going to function in our day-to-day clinical practice. Okay, so the vision, it does matter, but most meaningful change, it needs to we need to have the foresight for that sustainable change, right? Many clinicians have fabulous ideas out there. They can see the service gap, they know what patients need, and they might even know the equipment that's needed or education or the workflow, but they might get stuck with how are we going to move forward with it? Or we have all of these things now, what are we going to do with it? So we have to really think about that implementation part. That planning for implementation is so important. A strong clinical idea needs to have a defined patient population, a service model, a referral pathway, team members, a budget, a timeline, outcome measures, and a sustainability plan. In other words, we need to move from this would be helpful to this is what we are building, this is who it serves, this is how it's going to work, this is what it will cost, and this is how we know it's going to make a big difference for these patients. Um, we might have to think about a business plan. And sometimes people think about business plans of only, within, the business world. But we are in the business world, even though we're in healthcare. Um, we have to use that as an advocacy tool, and it's going to help us organize our clinical vision to make sense with administrators, funders, and physicians. So it helps us provide that structure. So, business plans, that's going to be asking, what are we building? Who is it serving? Why is it needed? Who are the other people that need to be involved? Maybe you want to start a fees program, which is fantastic. But, and we think about fees as this solo practice, which it can be. But if you're working in a system, you're probably going to need sterile processing involved, and you may need to have a tech involved to help get your scope over to sterile processing. So that's adding in more people to the mix. And so we have to think about that and how that's going to impact the bigger system, and making sure that all of these team members are available and ready to go to help be successful. We also have to think about how is success measured, and sometimes that's not necessarily just data points of revenue. Maybe it's also looking at productivity. Maybe we have better efficiency, or patients are being able to get in better. So we have to think about all those different options. Um, a sustainable program, it's really not built on one person alone, and it shouldn't be built on one person alone. We really need to think about the team and the workflow of the team, because if you retire or if you move, you don't want that program just to burn to the ground. You want this to be continuing past your time. You want this to be your legacy, right? That you helped this get started and it's continuing. So we have to really think about who has to be involved in this project for it to actually work. And after the team is identified, then that workflow is going to be built. You might have to start thinking about considerations for referral sources, eligibility, scheduling processes. Maybe this is a unique evaluation, and so you need more than your average time. So for us, we most of our evaluations are an hour, but when we do endoscopy, we reserve an hour and a half because it takes us time to prepare the scope, to get it over to sterile processing, and to clean the room and to make sure that it is clean and ready for the next, set of people coming in. We also have that extra time, which is really nice and generous, so that we can educate our patients after the procedure is done. So other considerations you might think about is documentation, safety requirements, communication amongst team members, and maybe any follow-up plans that need to happen. Outcomes, again, are very essential for sustainability. If we want that project to continue to grow or receive further further funding, excuse me, we need to be able to show what happened because of that support. So I mentioned before different types of outcome measures. It could be number of patients served, referrals, maybe a hopeful reduction of wait times. Maybe you start tracking how many instrumental assessments are completed this year versus last year. Maybe you can do patient satisfaction scores. That can be really helpful too. Or provider satisfaction. Your providers might say, wow, these patients are getting phenomenal care now, and use that to help support your program. Or tracking access to care. I think that's a really big outcome measure that can be helpful. And funders want to know that their support mattered. And when we track those outcomes, we honor that support and we build trust for future opportunities. So make sure to share some of those good findings that you have with others. So my closing thoughts here, big takeaways: build those relationships, make those connections, share your passion, be genuine. That's a big one. Be a genuine person, be a good person, give back to your community, show gratitude for those who do good for you, and take risks. It's that old saying, you miss 100% of the shots that you don't take. So don't be scared when you hear the word no. Don't be discouraged. I've heard the word know a million times. But I keep trying, and when you keep trying, you're gonna hopefully have some good outcomes in the future. So thank you. I know I'm happy to stay and answer questions. I know I went a little bit over, so my apologies.
No worries. The webinar was great, so thank you so
Oh,
much,
good.
Mallory. And I know there's a lot of questions, a couple of housekeeping items, and then we can dive into those. There were a lot of questions just about the S-bar that was mentioned. Some people were interested in accessing an S-bar for TIMS for fees or MBS. So I did put the information in the chat. We have those. So I messaged everyone who messaged me and grab their information. But if you didn't get a chance to message me, just send me an email. My email's in the chat, and I can send you that resource. And then last housekeeping items, if you'd like a certificate of completion, just send me an email at tims-shannon@tims.com. And then the survey for ASHA CEUs was in the chat, and it'll be sent out via email as well. Okay, so let's dive into some questions. There are several. Um, Okay, this person said, I find that management is the biggest barrier. How do you get them on board when advocating? We have a physician on board with us, but getting management to agree has been a challenge.
I guess I would try to come to the place of what's their hesitancy in wanting to move forward, right? So, maybe that manager is seeing some barriers that they haven't shared with you, and maybe you can help problem solve with what those barriers could be. So again, I'm really lucky. My manager and I have a really good open relationship where I can say an idea and she says, well, we've kind of got X, Y, and Z going on. And okay, well, this idea needs to be pinned for another time. Or maybe it's okay, I like this idea, but what about X, Y, and Z? But we have that relationship that, she feels very comfortable with telling me those things. So maybe I would, go from that standpoint of, are there specific concerns that you see with this idea? And is there a way that I can help problem solve some of these things?
Wonderful. This person said, I really appreciate your guidance, and I agree manager buy-in is so important. How would you proceed if your direct manager and their manager listen to your proposal for fees and agree that there's a need, but ultimately say no due to budget? If you don't have the support of a manager, how would you keep moving forward without going above them?
I would ask them, I understand that budget is a big concern. How would you feel about me starting to explore if there's any nonprofit opportunities, or if there's a hospital foundation? Could I start looking to see if there's anything available out there? And they might be very supportive for that.
I will also throw in specifically about fees. You could also pitch to them the potential for like a pilot program using single-use scopes, which is much more affordable than some
Mhm.
of the reusable like high-res options. So just know that, that could also be something that's on the table that I've seen customers that work with Tim's do.
Mhm.
Okay, I'm gonna scroll up here because we've got a lot going on in the chat. Let's see. Oh, yes, there was a question specifically for you about strobe. Someone wanted to know if you had any recommendations for more intensive fees and video stroboscopy training, like in the range of 1 to 2 months.
Oh. Um, well, I can just tell from my personal experience. I know when I was trained versus now there's a lot of people out there now doing training. So, but for me, where I did my training, I had Dr. Eric Blicker, who is wonderful for fees. And then I also went down to Emory, down in Georgia, and they did fees and video stroboscopy, which was really nice. Because there's a lot of places that might only do fees, but it was nice having that support for video stroboscopy. But another big thing in our facility is that we had, I was lucky to come into a program that already had clinicians who were previously trained, and so they were mentors to me. And I serve as a mentor now to other clinicians at my hospital when we're learning. But I'm also kind of picky in the sense of I'm happy to train anyone, but I also think it's I know that I don't know everything, and so I think it's important to learn from other people too, learn other styles and other considerations. And so I really like it when people can go to, other formal courses. So, but those were mine. I'm sure there's a lot of other great ones. I think one of my colleagues went out to California, but I can't remember exactly where. So,
Yeah, I can also attest Dr. Blicker's courses are fantastic, for specifically for fees. I
mhm.
think we might have actually got all of the questions. I know there was a ton going back and forth in the chat just about additional resources. One person did want to know if the resources that you mentioned, discussing the differences between MBS and fees, if those are available somewhere for download. I will say before you answer that, Mallory's slides will be on the Tim's website too. So all of the information she provided with like the templates and things like that, will be available for download this evening.
Mhm. I I think I could maybe make something. I'd have to check with my manager because we kind of made it specific to our facility, but um maybe if I edit some things out, because of course, like our system processes are probably a little different than yours, but I'm sure I could maybe make a little something and I don't know, I could send it to you, Brooke, and I don't know if that could go on or not, but
Yeah, yeah, for sure. Whenever I know Mallory is, as she presented, she does a ton for her local community and nationally. So, when you have time, that would be great, but no pressure or rush. I will say to the attendee who asked about that, just send me an email at tims-edom@tims.com. We have a ton of free resources, going through the differences between MBS and fees. I did a almost 2 hour webinar on the topic, about a year and a half ago, and those slides are on the Tim's website. So I'm happy to send you that direct link, and you could download that and, use it to, make your own handout as well. But with that, I just want to thank everyone for joining us this evening, and thank you, Mallory, for your time and your expertise and just all that you're doing for your local community and the wider speech pathology community nationally.
oh, thanks. Thank you.
Awesome. All right, everybody. Well, thank you so much for joining us, and we will see you at our next webinar. Bye,
Thank
everybody.
you, everybody.